Right now, for the management of patients with EGFR mutant non-small cell lung cancer, we have 3 TKIs available in the first-line setting. Those TKIs have been compared to chemotherapy in the setting of EGFR positive non-small cell lung cancer, Gefitinib, Erlotinib, which are first-generation TKIs, and Afatinib, which is a second-generation TKIs. We also have data from the FLAURA trial that compared Osimertinib, a third-generation TKI, to Gefitinib or Erlotinib, but currently Osimertinib has not been available in Europe. So we have an historical sequence that is first-line, first-generation, second-generation EGFR TKIs, followed at the time of resistance with chemotherapy, and then possibly a re-challenge with those TKIs, because we know that EGFR mutant clones may actually proliferate, have a higher rate of proliferation, and this is a pathogenesis substrate for sequencing TKIs, chemo, then again re-challenge with those TKIs. We now have an additional option, that is Osimertinib, after the failure of first, second generation TKIs in the setting of T790M positive acquired resistance. So it means that we have to rebiopsy the patients to identify T790M, so it may be tissue rebiopsy or liquid rebiopsy, to identify T790M, and in T790M positive patient in the second line setting, initiate Osimertinib, with the opportunity, after the failure of Osimertinib, to do chemotherapy and possibly TKI re-challenge. So we have this strategy that is driven by the identification of T790M at the time of acquired resistance to first, second generation TKIs. Osimertinib has demonstrated superiority versus Gefitinib and Erlotinib in the first-line setting. This is a FLAURA trial, 19.9 months versus 10 months for first-generation TKIs. So sequences are now being re-evaluated with the opportunity to deliver Osimertinib in the first-line setting. But then the question is sequence. What will we do after Osimertinib? The issue is that we do not know that much the resistance mechanisms. It seems that those resistance mechanisms to Osimertinib are diverse, may not lead to an eligibility to targeted treatment. So after Osimertinib, maybe a majority of patients will have to receive chemotherapy. We also need to know what are the overall survival of those patients in the clinical trials, mature overall survival data from FLAURA, but also from the AURA3 study.